Hello everyone, my name is Paula Rugg. I've been a registered nurse for 21 years and have spent the last 8 years in primary care at the White River Junction VA. I struggled initially with a capstone idea, but I knew exactly who I wanted as a mentor. I approached Brenda Sherman, our wound ostomy nurse, and she just happened to be working on a project that involved pressure ulcer prevention in primary care. She was eager to have help from someone on the inside, so to speak. Pressure ulcers have been a major focus for inpatient settings, but there has not been a lot of research focused on prevention in outpatient settings. I'll start by identifying the problem, how it applies to our primary care setting, and my specific objective. We'll talk a bit about pressure ulcers, the risk factors, and some numbers. We'll look at how pressure ulcers impact the lives of our patients and the healthcare system. I will discuss some characteristics that make veterans a special population, and talk a bit about the registered nurse's role in primary care. Next, we'll talk about my creation process, and we'll review survey results from other primary care nurses and talk about what comes next. The Veterans Health Administration Handbook from August of 2016 includes a skin care protocol for the prevention of pressure ulcers. The goal is to standardize screening, assessment, and prevention of pressure ulcers in all settings. In spite of a written nursing protocol, our outpatient settings have not implemented any procedures. Recently, all VA facilities have come under some pressure to change this. The protocol's guidelines for the primary care setting states that every patient is to have an annual pressure ulcer risk screening. Any patient found to be at high risk is to have an assessment, education, and if necessary, care planning. How do we meet the protocol requirements of standardizing assessments and documentation in a busy primary care setting? My goal became to create a template that would be easy to use, follow the National Pressure Ulcer Advisory Panel's guidelines, and streamline the assessment, educational, and documentation process. Pressure ulcers are defined as localized injury to skin and/or underlying tissue as a result of pressure or pressure in combination with shear. They usually occur over bony areas such as the sacrum, hips, tailbone, heels, and the back of the head. The strongest independent predictors leading to pressure ulcers are patients that are confined to bed, wheelchair use, and have limitations in their mobility. Other factors can contribute to a patient's overall risk level as well. Poor nutrition or tissue perfusion can impair the skin's ability to tolerate pressure. Cognitive impairment and lack of sensation can decrease a patient's awareness of discomfort and need to change position. Pressure ulcers have devastating effects on patients' lives. For the patient with intact sensation, there's a great deal of pain. There's risk of infection that can lead to sepsis, even death. Lengthy hospital stays and rehab stays are not only expensive, but costly in terms of quality of life and social isolation. There's also the legal proceedings that may be involved if there's a question of neglect or medical malpractice. In October of 2008, the Centers of Medicare and Medicaid Services declared that they would no longer authorize additional reimbursement for the treatment of certain preventative conditions like pressure ulcers. Pressure ulcers affect approximately 3 million Americans at the cost of nearly $11 billion a year. The cost of treating just one single full-thickness pressure ulcer can be as high as $70,000. The mortality rate of a patient with a pressure ulcer is 2 to 6 times greater than that of a patient with intact skin. And if a patient is elderly, we're talking 400% greater. I've been working with the veterans since 9/11, almost 17 years. Generally speaking, veterans are less healthy than the general population. In a 2013 retrospective study of 29 veterans with nosocomial pressure ulcers, revealed that 90% of them had at least 3 comorbidities and twice the incidence of diabetes than the general population in similar studies. In service to our country, many of our veterans have been exposed to hazardous conditions that have lifelong health implications. Each military conflict presents different health issues. Agent Orange exposure during the Vietnam era has been linked to the development of diabetes, eczema, Parkinson's disease, early onset peripheral neuropathy, chronic dermatitis, and several types of cancer. Veterans serving in Afghanistan and Iraq were exposed to the toxic smoke and dust of burn pits. Jet fuel was used to burn all kinds of waste, every kind of waste, plastic, chemicals, human waste, medical waste, even appliances were burned. Cold injuries and frostbite can occur when veterans are stationed or training in colder climates. This can lead to possible neurologic and vascular injuries. Advancements in protective gear and medical treatments have had some unintended consequences. Combat vets can survive injuries that would have been fatal in the past. As a result, we see traumatic brain injuries, post-traumatic stress disorder, and multiple traumatic amputations. When I first began discussing my project at work, I found nurses and providers were resistant. The attitude was that we did not need a formal process to recognize a patient at risk. We know our patients very well, and our experience and clinical judgment skills were all that is needed. My literature review turned up little research specific to pressure ulcer prevention in primary care, but I did find studies that focused on this very perception in acute care settings. The evidence suggests that clinical judgment is indeed effective at identifying patients at risk. In fact, it's just as effective as the use of a formal risk assessment tool such as the Braden scale. However, it's when nursing knowledge is used in conjunction with a formal tool that care plans get implemented and patient outcomes actually improve. I was also surprised to learn that my mentor had no idea how primary care operates on a daily basis, what the flow is like, or what nurses actually do. So what do primary care nurses do all day? The VA uses a patient-centered medical home model. We call them PAC teams. This model intends for every team member to be working at the top of their credentials. The RN role is intended to be one of care managers of complex patients. Nurses have their own scheduled patients and phone calls and interact very little with the patients being seen in routine visits with their provider. According to a study of a primary care clinic using the same model, the amount of time actually spent on care management is quite limited, unplanned, and reactive. This is true of our clinic as well. The reality? Nurses spend most of their time on a variety of simple to very complex tasks that come at them from multiple directions at any given time. How are we going to fit in time for skin assessments? Creating a documentation template as a progress note was not going to be enough to ensure that it was done annually. I envisioned a clinical reminder that would turn on annually, prompting its completion. The VA has many such reminders. Mandatory ones are created nationally, others are created on a local level. Some national reminders are layered or branched. A screening reminder is completed by support staff. If the screening is positive, it turns on the next reminder, an assessment by qualified staff. This type of reminder allows staff to work to the top of their licensure. This is what I envisioned creating, but I didn't know if one could be done on the local level. Our clinical applications coordinator, referred to as CAC, was not sure how to create such a complicated reminder. She did know that it would be much easier from her standpoint to modify an existing template than to create one from scratch. The inpatient template was nationally created and could not be modified. So how was I going to find one to modify? I needed to find out what other VA sites were doing. Maybe someone had a working process that we could learn from and build upon. I emailed the primary care nurse manager at the Manchester VA. I also posted an inquiry on bulletin boards of 2 separate VA special interest groups. I received 3 very different responses. Manchester had created a layered reminder and templates. She sent them to me in the form of screenshots. My mentor and I spent many hours discussing the features and modifying them, and I presented the final design to our CAC, Nancy. Still unsure of how this layered reminder was supposed to function, Nancy and I met with Manchester's informatics nurse through a video conference. This demonstration was instrumental in giving me the confidence we could make this work. It also gave Nancy the required guidance she needed to create our own set of reminders and templates in White River Junction. So the clinical reminders themselves. The screening goes back to those greatest risk indicators we talked about in slide 5, impaired mobility and activity. Any patient who is bed fast, chair fast, or needs assistance in transferring are at high risk. We also ask about pressure ulcer history. This quick screening step can easily be completed by the health tech who completes vital signs and other reminders. A positive response to any of these screening questions turns on the second clinical reminder, the assessment. An RN will perform the Braden scale, skin assessment, education, and skin documentation. The assessment template was designed to be as standardized and easy to use as possible. I didn't find any research to indicate the best risk scale for outpatient settings. Remember that a formal tool in conjunction with nursing knowledge is important for improved outcomes. The Braden scale is the most commonly used tool and has the highest validity for inpatient settings, and it's the scale the VA uses for inpatients. So we start off with the Braden scale. Next come dialogue checkboxes for describing the patient's skin. Is it dry, moist? Is there rashes, bruises, edema? If a wound is present, more dialogue boxes will walk the nurse through proper measuring and staging criteria. Check boxes for wound tissue types, exudate, and signs of infection all include brief descriptors to facilitate thorough, consistent wound documentation. An education section allows for free text. It also provides a link that allows the nurse to print out a patient-friendly pamphlet. This pamphlet has been previously designed by our wound care nurse, my mentor. I reviewed the information it contained to ensure it was up to date. My research process had uncovered a VA-designed mobile app to help patients and caregivers prevent pressure ulcers. This resource information was added to the pamphlet. Finally, the template includes direct links for ordering wound and nutritional consults. Once we had a working prototype, I wanted to get feedback on this template. I knew this was asking a lot of my peers. It would take more time than just answering survey questions. I asked 13 primary care nurses to play around with the template in the electronic chart of a test patient. I was interested in finding out if the overall design and layout were easy to use. How effective was it for documenting? I also wanted to know what obstacles might prevent nurses from using it for a real patient in clinic. I received 6 surveys back. The format and ease of use was unanimously positive. Nurses liked the idea of links for education and consults, but the links didn't function properly. 2 of the 6 respondents commented on how easy or how pleased they were with the descriptions provided in the wound assessment portion. 2 people also commented on the Braden scale. It was not clear that this portion was required before they could exit the template, and this caused some confusion. Several themes arose as perceived obstacles. There is concern about the time it would take to complete skin assessments on all patients who might be at risk. The White River Junction VA has more than 10,000 patients. On average, there are approximately 100 scheduled routine visits a day. The number of walk-ins and patients scheduled in the nurse clinics fluctuates on a daily basis. There is real concern that demand could easily exceed nurse capacity. An RN that transferred to our clinic recently made the comment to me that of all the positions she has held at the VA, she has never been as busy as she is in primary care. Patient and clinic flow is another theme. We don't have enough exam rooms for providers to use more than one room. After a patient has their vital signs taken by the health tech, he or she returns to the waiting room until the provider is finished with the previous patient. There is also the attitude I mentioned earlier, that we don't need to be doing this. We know our patients. So what's next? We need to do some tweaking of the template. We need to fix the links so that they work properly. We need to label the Braden scale as a required field. We need to establish a training session as a refresher on wound assessment and documentation. We'll need to conduct a pilot study on one team to come up with a way of incorporating this task into the clinic flow. Spreading the process to other outpatient settings like urology, outpatient surgery, and CBOCs will need to happen. CBOCs are community-based outreach clinics. We have 7 of them scattered through Vermont and New Hampshire. They provide primary care as well. And finally, we'll need to develop an annual competency module. Thank you.